I'd like to address the state of diabetes in Canada, share a few stories, highlight what diabetes means to governments and business, and conclude with CDA's strategy. Diabetes in Canada is like a tale of two cities. It reflects both the best of times and the worst of times. On one hand, there are many reasons to be hopeful and encouraged. Society has made great progress in treating diabetes since insulin was discovered by Banting and Best in 1922 in Canada. It's been nothing short of miraculous. Today, millions of people are living, have lived, because of that discovery. Because heretofore, if you had diabetes, it was a death sentence. Basically, your body wasted away. And if you can imagine, if you've ever been to the wonderful Banting Museum in London, you can see pictures of children who basically were held starving so that they could have a longer life because they couldn't process foods in the same way. It's really incredible. Today we are much better at treating diabetes thanks to the introduction of pre-insulin drugs, new medications, blood glucose monitors, high technology insulin pumps, and the expertise of our dedicated health professionals, researchers, and members of our life science communities, a number of whom are here today, and we thank you on behalf of CDA with people living with diabetes. You know, it has made diabetes an easier disease with which to live, but it's easier, not easy. But there are hopes, but there are also concerns. By 2020, 33% of Canadians will have diabetes or prediabetes. That will add an incremental $16 billion in diabetes costs alone to healthcare. That is an enormous number, and it's not getting any better. So before I move on to diabetes in general, let me talk about a few stories. My friend Phil Bobowski, who's a regional chair in Calgary, has had diabetes as the root cause of many of his health problems for many years. 8 years ago, he lost his sight, so Phil is blind. Soon after, he developed kidney disease, which required a kidney transplant. Phil does his best to live a healthy lifestyle, and in fact, as regional chair, lives as well a life, as normal a life as you can. But it's a daily struggle. And he has many, many challenges ahead of him, and the stakes are quite high. And for those of you who are using your Blackberries, please, or iPhones, this will be available, I think, either Blockbuster's not long, but maybe on CNN or Netflix within 2 years. So Arlene Gramble-Granowski is a retired Manitoba police officer who living with diabetes since 2003. Now she had a different issue. What happened is she was misdiagnosed and her prescriptions were changed. And as a result of that, she suffered huge mental health issues and huge physical issues. She couldn't walk more than 10 paces. She couldn't get off the couch. She couldn't work anymore. And so one of the things that we've tried to work with is the communication, the education between patients and healthcare professionals. And do it in a sense that they don't turn to Dr. Google for everything that they want to know. For families, it's even more difficult. My colleague Pauline Armour, who had worked in the life science business and has joined us in our mission funding, has a 17-year-old daughter. For 14 years, she's had to wake up in the middle of the night to test her daughter for type 1, to make sure that her sugar levels were at the right level, to make sure that she didn't go into a seizure, a coma that could lead to either hospitalization or death. Now, can you imagine the responsibility on a parent to do that? And so Pauline, she has, in effect, the dreams of every parent, that her child would have a better life than her, that she would go on to university or college, but she has the nightmare that many of us do not. What happens when they go away? I mean, it's tough enough to go to college when you don't have diabetes. Imagine when you do. So make no mistake, having diabetes affects your life and your health in many profound ways. It's a very serious disease that can send you to the hospital and that can potentially end your life. So what is diabetes? Well, when you have diabetes, basically your pancreas no longer produces insulin for your body to use. And insulin, as you may know, is necessary to transform sugars in our food into energy. Now, when you have type 1, your body cannot produce insulin at all. So there's no transfer. So without insulin in your system, you will die. And so for the 300,000 people who take insulin every day as type 1, there is no cure and there's no way to prevent it. With type 2, your pancreas either does not produce enough insulin or your body won't absorb the insulin. So the almost 3 million Canadians with type 2 and the 1 million people with undiagnosed diabetes use either pre-diabetes drugs or insulin. But again, when you think of the 1 million who don't, who are at risk, it's an amazing kind of situation where one day you cross over that line into a game-changing, life-changing disease. And that's why we partnered with Sun Life and the Public Health Agency of Canada, and thank you to both of them, to run the Don't Be Risky, Get Tested campaign in November, of which I will speak a bit more later. Now, diabetes is not a democratic disease. It does not affect all people equally. It tends to deal with people who are marginalized, disadvantaged, lower income. It deals with people of different ethnicities, different ages, family histories, and lifestyle factors. And while we can modify some of those, we cannot change all of them. Now, another almost 6 million Canadians have prediabetes, and that's where their sugar levels are high enough to be of concern, but not high enough to be classified as having diabetes. The key, though, is that half of those people will go on to get diabetes. So the numbers just keep growing and growing and growing. As I stated earlier, that means that now somewhere around 28% of Canadians have diabetes or today, and that's more than, or prediabetes, and that's more than 10 million people. By 2020, it'll be over 1 in 3 will have diabetes or prediabetes. And so we can't believe that we will alleviate this disease simply with a magic pill or a miraculous insulin that comes out you can take once a month or once a year. It's just not that simple. Diabetes affects people, and those of you who have it, 24 hours a day, every day. It represents a lifelong challenge of balancing diet, exercise, blood monitoring, and medication. There are no vacations, no breaks, no time off, no recesses. It is 24/7, 52. So if you have diabetes and you're sitting in this room having this lovely lunch, you will be looking at everything you eat. You will be making a mental calculation of how many carbs, calories are in everything that you just had. You will make a mental calculation of how that will affect your blood glucose level, and therefore how many units of insulin you may have to give yourself. When you leave the room, you may need to note, where might I find juice or chocolate bars if something happened? Where might I have to go if I have to inject? Because I may not feel doing it right in front of the elevator. And that's for, imagine if you're a mature adult thinking about that. Imagine if you're a child. Imagine if you're a teenager. And I've spent time in medical offices as part of my job working with endocrinologists and having young teenagers, young adults come in with paper trails on what they've got and trying to keep the numbers together. It is not easy. So don't get me wrong, it is possible to live with diabetes, and it's possible to live well. Many people do it with the help of a supportive team, supportive healthcare workers, supportive families, medications, devices, and supplies. But it puts your health at great risk. So let me illustrate. If you walk into the Ottawa hospital today and you looked at people being treated for heart attacks, 40% of them will have diabetes. If you look at stroke victims, 30% of them will have diabetes. Of the people on dialysis, 50% will have diabetes. Of those with non-traumatic limb amputation, 70% will have had diabetes. And 85% of those amputations are a result of non-healing foot ulcers. We have our colleagues at the back of the room who deal in that area. Because as a vascular disease, you begin to lose feeling in your outer extremities. So often people with diabetes could walk over cut glass and never know. Nearly 1/3 of those people will die within a year, and 2/3 within 5 years. The mortality rate is higher than almost all types of cancer. So people with diabetes don't just die of diabetes, they die of the complications. And that's why we're working so hard with people such as the Heart and Stroke Foundation, the Arthritis Foundation, the Kidney Foundation. Because one of the challenges we have is to work collaboratively to do this together. And I'll speak a bit later of our great partnership with the YMCA. Disease is also a leading cause of vision and blindness. So people with diabetes are at a much greater risk of depression and mental health challenges. So because of these and other health impacts, people with diabetes can live up to 5 to 15 years less than I will. So remember that these health impacts come at a time when less than 10% of the population has diabetes. Imagine the oncoming tsunami of 33 to 35%, resulting from people with diabetes, pre-diabetes, at risk of diabetes. And diabetes is very costly. Those who live with diabetes can face thousands of dollars in out-of-pocket expenses every year for items not covered by provincial health plans. And I would like to say thank you to the provinces. You know, in times of austerity, it is tough, and we want just a little bit more than our fair share. But I will say that they try as much as they can, and we appreciate what they do for people with diabetes. But imagine not being covered for medications, devices, and testing supplies. Imagine needing an insulin pump, which can cost from $6,000 to $8,000. So while this is a challenge for middle-class Canadians, imagine people with low incomes. It means that they have to make choices, such as buying inexpensive, less healthy food, or decreasing some aspect of your treatment. When I was a president for a company for Walmart, and I lived in Arkansas, I used to call it the land of the big gulp, you know, because we were the second poorest state in the nation. And it was easy to eat for $4 a day. If you wanted a ginormous hamburger, a 32-ounce, soda, as they called it, and a whole bunch of French fries. Filled your tummy, but it sure didn't help with diabetes. So how big is this problem? I mean, just a few years ago, we surveyed people living with diabetes and found that 60% did not follow their medication plans. Why? Because it was too expensive. I remember talking to a young lady, young woman, 2 children living in the Jane Finch area in Toronto, which is a low-income neighborhood. And she said, you know, Rick, you tell me to eat healthy, but apples are $5 a pound, and I don't even have a store in my community with fresh fruit. Do you know that it costs me so much for my medication. I have to make a choice. Buy my medication or put shoes on my children to go to school. That's the choice that those people make day in, day out. The average out-of-pocket expense for someone on a Canadian average income of $43,000 is over $2,700 per year after tax. If you live in a jurisdiction like New Brunswick, with your medications and other devices, your cost will be over 10% of your pre-tax income. 10% of your pre-tax income. Doesn't leave a lot for food and rent and kids, and certainly not for vacations. So as the prevalence of diabetes increases, the cost will increase. In terms of the healthcare system, the cost will be approximately $14 billion this year. In 5 years, it's grown to $16 billion. And these costs affect every Canadian, every employer. You know, there are health taxes. There are costs to the healthcare system. And so even if you don't have diabetes, this tsunami will also hit you in the pocketbook. And we are concerned, therefore, with access to healthcare and its increasing costs today. All governments are. But diabetes is one of the key drivers of those ever-increasing costs. For businesses and employers, we face an enormous toll as a cost toll as a result of diabetes. For example, it's estimated that disability and premature death arising from diabetes will cost more than $12 billion in lost productivity alone by 2020. Our costs at CDA, because we overskew in people with diabetes, as would other health charities with people with their own diseases. Our health and pension costs are 30% more than the norm of any other company. 30% more. Now imagine as a business, as this tsunami continues, that your healthcare costs go up by 30%. That's a big number. Think of the time employees need to take off for themselves or their families to visit multiple touch points. Doctors, endocrinologists, diabetes educators, specialists, hospital tests, etc. So with any sense of exaggeration, I can say that diabetes is the most important chronic disease epidemic of our time. I don't take away from any other health charity. But we haven't talked about this before, and we need to get real about what's going to happen coming ahead. We just simply can't stand on the sidelines anymore as this tsunami approaches. So we know it's a complex problem, and we know complex problems don't usually have simple solutions. We are rightly interested in the determinants of health, and I want to point out organizations like the Public Health Agency of Canada who look at social determinants of health. For improving access to care and social services. As I said earlier, given the fact that diabetes affects more people at the lower end of the social income scale, we have to look at innovative ways to help those high-risk people. We have to understand that communities such as Aboriginal communities, both on reserve and urban, and our new immigrant communities, have much higher prevalences. We have to make sure that we're culturally appropriate. As one of my board members says, I don't have peanut butter on my roti. And so therefore, we have to think of what this can do. Our Asian and South Asian populations are at huge risk of diabetes, as are our Aboriginal, that will suffer 5 times the rate. That's why we're putting together great partnerships with the National Aboriginal Diabetes Association. Why we're building partnerships and chapters in our local communities, our South Asian chapter, our Asian chapter, and other ones across the country. That's why we're building programs with the Congress of Aboriginal People. That's why we've reached out to our partner at the YMCA and In fact, I should really say they reached out to us, as did the Public Health Agency of Canada, because they have 1,000 touch points across this great country of ours. And by working together, we can reach more people to help create a better society. Now, the CDA is a full-service organization. I like to say that, some of you know I had a business background before running organizations, and I came into the not-for-profit about 14 years ago. So I like to say in a way that the CDA is the department store of health charities. That's assuming that department stores are doing well, which some of them are. So let's say they're doing well now. But you know, we provide services. We provide programs. We have 35 offices across the country. We run a social enterprise, which is called Clothesline, which picks up clothing. And 100% of those profits go to Canadian diabetes. And just a little commercial here, if I could. I'd love you to put your clothing into a red CDA bin. But if you're not going to, please put it into a bin where the money actually does go to a health charity, rather than one that pretends to be a health charity and takes 99.9% of the money and puts it back into their company. Just a little aside. So the first thing we try to do is to help people with diabetes effectively manage their disease. And this requires a number of things, such as access to fundamental tools like medication, devices, supplies. It also means helping people living with diabetes receive the support from a team of healthcare professionals and family members. And so for us, self-management is job one. We need to ensure people with diabetes live productive and healthy lives. Because there are times when people with diabetes need the help of healthcare professionals on a daily basis. And that may sound easy if you live in Ottawa and have a family dog. But it's hard to believe that almost 50% of the people living in North Bay do not have a family dog. It's hard to believe that people living in northern communities have no doctor at all, and not even access. And that's why we provide programs like 1-800-BANTING and what we call the virtual CDA. Now let me give you a concrete, inspiring story about people with diabetes and dealing with helping them. We have a camp here, Perth in Maberly, that operates Camp Banting. It's our first camp. It's been around since 1953. You know, interesting, our organization deals with more type 1 youth than any other organization in this country. We put thousands of kids every year through diabetes camps, and we subsidize every one of those children to the tune of $2,500 per visit. That's where your donation is going. Thank you. And so at camp, kids with type 1 get to do things they never got to do before. The first thing is they realize, my God, there are other kids with type 1. I'm not alone. You know, I'm not that different. The second is they learn how to self-monitor, self-manage their own disease. Now, our camps are very expensive to run because we have healthcare professionals there that are checking those children 2 to 3 times a night. So it's a tremendous opportunity, and when I go to those camps, it's extraordinary. It's just extraordinary. And it makes me feel so good. My wife and I go up every year to spend some time, and it's a wonderful experience, and you're invited to go anytime you want. But it's also probably the first time in many, many years that their parents have had the night off. Because their parents had to wake up every night. I mean, if some of you are parents, can you imagine that you actually get to sleep through the night, much less till like 11 and then have breakfast? The second is prevention. Since more than 90% of the population has type 2, and we have 5.7 million people who are in a pre-diabetes stage, it's very important that we help people prevent the disease. This is the real opportunity for governments, for CDA, is to stop it before it happens. And so recently, as I spoke earlier, with the help of Public Health of Canada and the Sun Life, we ran our Can Risk campaign, which you should take. Over 40,000 people did. And it'll tell you whether you should really go see a doctor and have your blood analyzed. It was a very successful step in our journey, but more is needed to get more awareness. Third is our research to find a cure and help people live better with diabetes. We're proud of our history of funding research, and we've funded over $125 million in research through CDA. That's a lot of money. And we've been able to do this across Canada. The money that we raise in Canada is spent in Canada with Canadian institutions, because we want to grow the intellectual capital in Canada. We want to grow the opportunity to have, as we are on the way now, and if we're not already there, probably the best research community in the world, right here in Canada. In fact, this year marks our 40th anniversary of funding research. So let me give you two or three quick examples. Islet cells in the pancreas are what help generate insulin in our bodies. We've been working with Dr. Pierre Santamaria in Calgary, and he is working on a way to actually be able to transplant islet cells. And he's getting closer and closer. We're also working with Dr. Daniel Drucker, whose research has led to the introduction of drugs that help people avoid weight gain. Because some of the side effects of insulin drugs are weight gain, which one, doesn't help people as they move forward, because more weight is not good, but secondly, doesn't help them in terms of self-esteem, so it's not a motivator to take their insulin. Ici, on travaille avec Vincent Poitrou à l'Université de Montréal, puis on investit plus de 1 million par année au Québec. Puis on n'a pas de bureau au Québec, puis on prend pas d'argent du Québec du tout. Alors c'est incroyable vraiment. Les dernières 4 ans, 5 millions. Dans les universités comme Montréal, Sherbrooke, Laval, McGill. On an exciting note, let me tell you about our groundbreaking initiative to increase diabetes awareness and change perceptions. And let me start by your perception. It may come to you as a surprise that people with diabetes face discrimination in many ways. It's interesting when you have a particular disease that you would be stigmatized, that you may not get that next promotion. They may not think that you have the health or the dedication to working. I was speaking to a colleague of mine at arthritis who said, people don't identify either with arthritis. I said, why would that be? Well, because it's an old person's disease and they may not get promoted. So every charity has its stigma. But for ours, because of sugar lows and highs, people may say, well, you may have a reaction, and therefore I can't have you in a meeting. I don't want you on the executive team. It's a terrible, terrible stigma. Children in school are marginalized and denied a full school experience. They're not allowed to keep their supplies in their desks. They're not allowed to go out to inject their insulin. Imagine they're injecting their insulin in broom closets and bathrooms. I spoke to a mother the other day, it brought tears to my eyes. Her child went into a coma and almost died at his desk, literally, because the teacher would not allow the child to leave the desk because he had already gone out once. Can you imagine? Now that's not because it's a bad teacher. It's because they're not aware. And we've started this tremendous initiative called Kids in School, which we help to change that. So further, access to healthcare services and other supports vary widely depending who you are and where you live. It should not matter in this great country of ours, on basis of equity, that you should live or die based on where you live. it's wrong. And sometimes you have to do things because they're right, not because you have 28,000 pages of data. Access to culturally appropriate care and specialist services in certain communities, Aboriginal communities, are very difficult. Do you know that 50%, 50% of Aboriginal children will have type 2 diabetes by the time they're 20 years old? 50%. Out of that's Heather Dean's work out of the University of Winnipeg. It's tragic. So we released our diabetes charter for Canada, and it set out it's one of 3 in the world, and it set out a charter that had clear responsibilities for people with diabetes, for healthcare providers, for businesses, for educational institutions, for workplaces, for daycares, for schools. But I want to say it also set out to underscore the responsibilities of people with diabetes, that you needed to self-manage properly. You needed to advocate on your behalf. So it wasn't just this is everybody else's problem. It's our responsibility also. And so we look forward to empowering Canadians with diabetes and their caregivers to provide governments with standards of comparable access and care, to ensuring that people who live with diabetes are treated with dignity and respect, to enhancing the health and quality of life of the people who live with diabetes and their caregivers. And to date, more than 20,000 people have signed, and I would encourage you, as leaders in your community, please go to mydiabetiescharter.ca and sign this great document. It's a landmark initiative, and we'd like you to be a part of it. So in conclusion, diabetes is a tale of 2 cities. The best of times, because there's so much advancement, so much opportunity, and the worst of times, stigma, access, the government age of austerity, all of those things. But I am convinced that if we work together, and that is why I commit not only to work with Canadians with diabetes, but with our great partners in healthcare to create a better society for all. For those of you who are involved in public policy, we want to work with you as a catalyst to create a better system. I have tremendous, tremendous, tremendous respect for people working in government. There are times I wake up and I say, I have no idea how you get anything done in a system that really wasn't put together to get things done. You know, it's a control mechanism. That's what the bureaucracy was all about when it was set up in Rome. It was there to take care of the taxpayers' money. And yet, so many things are being done by our colleagues in government. And I would encourage you to take initiative, to take courage, and to move forward. For those of you in business, partner with CDA. Help us help you. Not only because it makes economic sense, because as stewards of your employees, it is the right thing to do. To those of you who are with other health charities, you know, I say to my friends in business, you think business is competitive? Wait till you work in a health charity. Because not only do we compete for a smaller bag of money, we actually have to be nice to each other. So we have to find ways why we should work together, not why not. Help us fund and find a cure. We want to let people with diabetes live healthier lives. We want to make Canada the best place to live. We want to take our enthusiasm, our energy, our knowledge, our commitment, our innovation, all the things that makes this country great, and put it against diabetes. We want to boldly go where no diabetes association has gone before. And we want you on that 5-year mission to discover new ways to help people, to discover new forms of making people healthy, to be there with us on this marvelous journey.